introduce our speakers. So obviously myself, I've introduced myself, and I'm from HQIP, which is Healthcare Quality Improvement Partnership, and we are a not-for-profit. We are best known for hosting the national clinical audits, but we now provide a lot of other services and do a lot of work around other areas like QI and evaluation. Obviously, today's session is as part of Clinical Audit Awareness Week, which many of you are very aware of, which we do every year in conjunction with NQICAN. And there are lunch and learns and prizes every day this week. So do join those sessions as well. And there's full details on the NQICAN and HQIP websites. Okay, the other group to mention, and Jorian is here fantastically helping us with today's session, is the Q community. So anybody who is not aware of Q community, it's a national community across the UK. There's thousands of people now joined. Everyone who is involved with that is networking, sharing, undertaking projects. It's got some fabulous resources. So the links are here for you to access, and do go onto the website and read a bit about what the Q community does, and thank you to them for supporting the call today. So our speakers, so the reason we're here really is a conversation that we had around, wouldn't it be great if clinical audit and QI could come together in a much more cohesive manner? And we had a small sort of working group to talk about what could we do for Clinical Audit Awareness Week to kind of raise awearness. And the lovely Nikki and Craig have offered to do a session for us. So we're really lucky that we've got such expertise on the call. And I know we're going to have a fantastic session today. So please do add questions in the chat as we go. But I'm going to hand over to Nikki. Nikki.
Nikki, you're muted. Classic.
There we are, sorted out. Thank you, and it's brilliant to be here. Thanks very much, Claire, for inviting me, and Craig for working with us to do this, and everybody else who supported it. So I'm just going to crack on. I hope you can see the slide. Can you see my slides okay, everybody? Fine, brilliant. So it's going to be quite a whirlwind tour through this. There's a little bit of polling that we're going to involve you in, and we really want you to participate. So you can watch the recording again if I'm going a little bit too fast, and put all your questions in the chat. So my journey started off as a pharmacist in hospitals, and actually I did audit, although I was just talking to Claire beforehand about the fact that I don't know that I was ever really taught clinical audit. And that's an interesting thing to reflect on later, that I perhaps haven't had the full training that I might have had. But nevertheless, I did a lot of audit. And then I moved from a hospital into primary care. I was one of the first pharmacists out there. And I started working on audit with community pharmacists, and then subsequently with doctors around sort of NICE guidance and things like that. And then I left pharmacy, and I retrained in quality improvement, and I had a really exceptional experience of training, very fortunate. And I saw all my colleagues doing quality improvement, lots of clinicians who were really good at it, and I kind of still felt not quite there yet. And the thing that really flipped it for me was when I did my own quality improvement project. So having learned all the theory and been exposed to really fantastic, international leaders in quality improvement, it was only when I returned to pharmacy actually to do my medicines management QIP that actually the penny really dropped and my confidence grew massively. And so I did a PG cert and lots of other things. So that was my little journey there. But my question for you today is, are you here to learn or to compete? You've seen the title of this, and hopefully we'll generate a conversation about this. You need to think for yourself where you sit on this spectrum of QI and audit, and really be aware of that, actually, because it's only by being aware of where we are ourselves that we can develop. So I'm going to bring the first poll and cut straight to the chase here and ask you to vote. So I'm going to ask Jerome to bring up the vote, and these are your choices, ranging from strictly audit to strictly quality improvement, with some bits in between. We're not going to have very long to vote. It's not a big question, is it? So maybe a big question, but it's very quick answer. So please vote as fast as you can. Zapping through the numbers. Great. Got a lot of you to get through, so just keep pressing your answer and we'll see where people are at. Oh, we haven't got a quarter of you yet, so a little bit more.
Wait, somebody pressed the button to end the poll. One of the hosts. Oh no.
Somebody ended it. Oh, do you want to just run it again then, Craig, and ask people to revote?
I can relaunch it. I can relaunch it.
I think everybody would want to play in if they can. Okay. So if you voted, just vote again. All right. There
okay. I relaunched it. Sorry about that, folks. It happens.
Brilliant. We've exceeded the number, so we know there was definitely an appetite for this out there. We're nearly halfway through with everybody answering. Wow, this is brilliant. Thank you for participating in this. This is really, really great.
Okay, should we share the results now, Nikki?
Yeah, I'll do a countdown. 5, 4, 3, 2, 1. And we've got at least 3/4 of you in that pot. I'm going to share the results, see what we've got here. I can see the results, but I don't know if they're there. Are they shared for everybody now? I think you have to press another button, don't you, to share the results. But if not, I can read them out. So what I've got here is 17%. So nearly 1 in 5 are strictly audit. In terms of quality improvement, much lower. So 9%, 1 in 10 are strictly audit. There's quite a lot of you looking to dance. There's a lot of audit people looking to dance with QI, and that's fantastic news. Nearly 30% of you. And there's a smaller number, but then there's a smaller number of people here who are looking to dance with audit. And we've already got 1/3 of you who are dancing partners. So that's fabulous. So thanks very much for doing that. One more quick poll now, just going straight on from that. Whether you do QI or whether you do audit, I'd like you to answer this question, the next poll that's coming up.
It was part of the same same
poll. Oh yes, scroll down. Scroll down. There we people have already done that. Thank you. Yeah. Oh wow, well there we go. It's what I do in my day job. So that's half of you. You're doing it as your day job. The next one down is you support people, you teach people, tell people, report on what's being done, something you're curious about or something you're interested in. So you were allowed to do more than one answer for that. So that's really great. That's helpful to me and Craig, because it just helps us understand where you're at for this. So we're just going to move swiftly on now with the rest of the presentation. I'm just going to, I think I'm still sharing my screen. So is that right? I'm still sharing. Great. Okay, so we've all come into healthcare, and predominantly, I'm just going to stop sharing the results now. Hopefully we've got a picture of that. We all came into healthcare because we wanted quality, and this is sort of definition that our esteemed leaders put together around quality. It's probably going to be superseded by another version at some point, because that's what tends to happen. But the thing about this is, when this word quality is used in these kinds of diagrams, it's really quite an umbrella term. And that's what they're describing here. So we're going to kind of dig down straight below that really fast. And we're going to look at improving quality and what we have at our disposal to do that. And what we've got here is Durand Trilogy. You don't need to worry about the name particularly, but it's a kind of a conceptual model, really, of what lies behind the whole drive for quality. And it has quality planning at its apex, quality control and quality improvement. So quality planning is quite often the business of strategic boards. It's very strategic in its nature, but it can also be done at a division on team level. We all plan what we're intending to do and think about why we want to do that. But quite often quality planning is a big thing in an organization. And then beneath that sits sort of two pieces, quality control and quality improvement. And the quality control is, as it says on the tin, and that's really where clinical audit tends to sit, under quality control and quality assurance. Whereas quality improvement is a different kind of set of skills and tools, and that's where something called the model for improvement, which we're going to talk about a little bit in a moment, that's where kind of the improvement methodologies that are science-based live as well. So this diagram is quite useful in helping us understand the relationship between the three pieces, and that they're all important to deliver quality and to deliver really good patient experience. So if we could dig down another layer below that.
Come on, it's only clinical audits.
Right, sorry. So under quality control, we've got the question, where are we failing against an established standard, or where are we succeeding against an established standard? So that's really where audit sits. And you do your audit and you're then thinking about how you implement change if you've got any gaps you need to close. Whereas in quality improvement, what we're really looking at about is what's the specific problem that we need to address. Because when you've identified a gap in audit, you don't necessarily, the audit itself doesn't tell you the nature of that gap. It doesn't really, it might give you a few indications about a bit more of the location of it, but it doesn't always describe the specific problems that are getting in the way of closing the gap. And that's where we use quality improvement. And then we use that to design what we're going to do about it. And I've got a picture of the model for improvement there, but I'm going to come back to that in a little while. So I'll move on and definitely come back to that for you. So if I just move on another piece, question here, can audit and quality improvement, that should be, sorry, really be dancing partners? Is it possible? And what I'm going to do now is give you two case studies, which I believe show that it is really possible and how important it is that we do dance together. I'm going to give you one micro one, and then I'm going to give you a macro one as well. So hopefully that will be a useful illustration for you about how I've seen this happen and how it's come together. So I have taught hundreds and hundreds and hundreds of people quality improvement, and we supported over 250 completed quips that we have in posters that people can see. So I'm going to use a couple of those as examples for you. This one is from Dr. Fred Smith. He works at the Dudley Group Foundation Trust, and he was on a course with us. And he came to the course with audit recommendation, which is one of the ways in which we bring people into quality improvement. It's not the only way, but it is one of the ways. And he was looking at the standards of audit. And you can see here, the graph on the left is from the Royal College of Emergency Medicine's Quality Improvement Project, a national report in 2018 and 19. And in their trust, they were sort of bubbling below. They'd been on a bit of a downwards trend, and they were bubbling around the mean and going below it. So he thought, this is an area I should work on. And one of the challenges actually for audit is it's sometimes quite difficult to get at the data because different people in the trust own it. And for him, it wasn't very accessible actually. So when he finally did get a handle on the data, the local data, the recent data, what he found was this wasn't a problem anymore. It had been sorted. So a really important lesson to learn before you start going off trying to make improvements. And you can see from his graph, they were meeting that requirement. So he then thought he'd look at something else. And he went back to another standard in the audit where they had also shown that they were going below the mean. And he decided to work on that. And this problem is when we send children home who've had fever from our emergency department, we don't tell parents what to do next. If unsure, then the delays can lead to harm. And if they're anxious, they return unnecessarily. So a sort of double edge here in not communicating well to parents. Undercooked, potentially risky, overcooked, extra work you didn't need to do, and extra inconvenience for the parents and children too. So he used one of the tools that we use in quality improvement. It's not exclusive to quality improvement, but it's called a fishbone diagram. And this is it here on the right, where the problem is in the head and you're looking at all the causes around it. And again, this is a sort of detail that doesn't come out in audit. So you find a gap, but you need to uncover and explore what your opportunities are to make a difference. And you will not be able to deal with all of them. You'll be picking the low-hanging fruit, the ones you think you can fix to start with, and then working up the hardness level as you go on. So I'm just trying to get my mouse up here again to move on. There we go. So this is the poster that he produced that summarized his work. And I'm just going to pick out the features for you so that if you have an audit background, you can sort of see the sort of things that we do in quality improvement quite typically. So we have a process map, we have a bar chart, we have, and this is all in the diagnostic bit where we're looking at what really is going on here. We then use the model for improvement, which I'm going to talk about in a moment, to come up with an aim and a measure. And the measure has a scientific robustness to it. So it has inclusion and exclusion criteria. And then you go into change ideas and your plan, do, study, act, or PDSA cycles. And you use a run chart or an SPC chart, statistical process control chart, to measure and know statistically if you're making a difference. So very similar to audit in terms of you're going to be using statistics in an audit quite often to look at norms and look at standards and see where you are, particularly when you're setting the standard for an audit. So he used audit as a springboard into quality improvement. So I'm now going to flip now and go into the piece around the larger bit. But just before I do that, those of you who are familiar with quality improvement might recognize this as a driver diagram. And what we're really saying here is you have an overall problem in the ED about management of children with sepsis, but you then need to break down that problem into the management of the different age groups, because your solutions for those age groups might be quite different. So this is around management of children under 5, then you'll probably have 5 to 12 or 13, and then you'll have young adolescents here. And you can see here that it's only these changes at this end, at the micro level, that drive the achievement of a goal here, which is where the audit is usually measuring at this level. But the quality improvement stuff is happening right down here on the right-hand side. So now I'm going to go to the macro level, and this is a project by a lady called Lucy Lewis, who's now a consultant nurse practitioner in frailty. And when she did this project, she was doing her training as part of the Wessex AHSN acute frailty audit. She'd been doing QI with me for 2.5 years when she got this, and she said, "Oh, Nikki, I've been given an audit. What am I going to do?" So we worked together to see how she could use quality improvement to help that audit. Now, I'm not going to read out all the aims because you can read yourself here, but the problem that the reason they wanted to do this audit really was that people living with frailty are at risk in hospital. We don't always identify them when they arrive, so we don't always give them the care that they need. So this was a simple articulation of the problem. And her design was to get the audit and train experts to collect data from 7 clinical areas across 9 acute trusts by December 2018. So that's a big ask. Okay, you can see the geography here, a whole load of hospitals. So we started looking at what would be the potential risk for her in undertaking this audit, because she didn't want to fail. She was doing a big, high-profile piece of work. So these are the problems for her: stakeholders, design, geography, and delivery. So she then did a process map to look at these issues for the patient's point of view. And she got some audit themes out here. She did lots of PDSAs to design her audit. All right. And you can see 6 articulated here, but actually you can see within this one here, she repeated the cycle 11 times. And that was to get to the themes, a consensus around the themes of what they were going to work on. So she used these tiny plan, do, study, act cycles to get to this point. And her results were pretty amazing. If you think about it, she got her data collection. They had 100% participation from 10 hospitals and 56 wards. Again, I'm not going to read it all out there, but she had amazing success at engaging people and setting the scene for the next step that the AHSN wanted to do. So she wasn't working alone. She was working with a team within the AHSN. It wasn't just Lucy doing her thing, but actually she was able to feed in a whole set of networks and experts to do this. So again, another really good example, I think, of how the two dance together really nicely. And this was her poster, which brought it all together and showed it off. That's on our website. I can give you the email address for that if you want to see it later on. So really the message here is about a sort of an idea that we can use the model for improvement and PDSAs to inject change into the audit that has already been done, to use it to drive that change, which is why we're doing audit. We're not doing audit to do audit. We're doing audit because people believe that this is an important thing and we need to get better and meet a standard. But how you make that change is a big challenge. And you will know if you work in audit that lots of people do lots of audits in their training and they go around the loop. And when they get to that fourth quadrant, they disappear on their rotation somewhere else, which it always feels to me like a real tragedy and a real waste of, well, I don't know, waste, that's probably slightly stronger word, but I think it could be more effective and it would be lovely if it was. And I think the dance would help us do that. So it makes audit, moving into this change, a real force for change. So I just want to unpick very briefly reasons for rivalry. This is a definition of rivalry, that it develops in the product of competition and ritualization between different parties. And I do think some people on this call will recognize that from both camps. There's a lot of challenges within organizations, especially as quality improvement and audit are increasingly being brought together in the same department. There's really uncomfortable feelings that people have expressed about position, power, pay band, influence, job role, etc. And these shouldn't be underestimated, because an organization makes a decision and it all changes. But actually people, us, we need time to catch up and to adjust. And we need support to find our way through that, to the dance. So it can feel very competitive. And I would just encourage you to really try and find people who've succeeded in this, to find good ways of doing this together. But I'm also going to just talk a little bit about misunderstanding, because that's kind of the area that I specialize in. And I teach a lot of people who swear to me that the two things, audit and quality improvement, are the same thing. So this is my dispelling of myth here. So, you know, most of us have a scientific background or of some sort, or have had that even in our management training. And you know, clinical audit comes from, you know, Florence Nightingale in the 1850s, but actually it had a real boost in the 80s and 90s when we started getting into clinical effectiveness and evidence-based medicine, because that gave us the standards that we were looking for in order to be really effective and use audit really well to improve quality. So this is what it's about, and it really gives, it's about compliance, and it gives organizations assurance that standards are being made. Reveals gaps, and it generates recommendations for change. So it looks quite similar to this other cycle here. You know, they've all got 4 bits, haven't they? But actually the plan, do, study, act cycle is shorthand for testing a change, and you do it in a very specific way, and you do it quite quickly. The thing that most people are less aware of is that it's part of this model for improvement, and I'll talk about that in just a moment. But if you just want a quick summary of why they're confused, they are different and useful. The thing that's very obvious for audit is it's usually a long cycle. It's often 6 months or 12-month cycles between your measurements, whereas plan, do, study, act cycles are really rapid. They can be done in hours, minutes sometimes, a day, maybe a week. That's a long time to be doing a PDSA. And they come in multiples, they come in series, but that's for a masterclass another day. So these are the essential differences. And the Plan, Do, Study, Act is a learning method developed by Edwards Deming, W. Edwards Deming, and you can read up about that if you want to. I didn't put it in the references, but there's a really good paper called Circling Back, which we'll put in the chat later on for you. So here's the model for improvement. Now, I teach, as I said, hundreds, I've taught thousands of people in my career in quality improvement, and every time I test people to ask them if they know this method, they don't. In nearly every audience, there's 3/4 of people who have heard of Plan, Do, Study, Act cycles, but do not know that it's attached to a method called the Model for Improvement that was actually designed and published in 1996 by people who'd worked with the guy who created Plan, Do, Study, Act. So this is the Model for Improvement. We don't have time to go into it in real detail now, but it is a robust method that gives scientific rigor and allows for some creativity in some places, but not everywhere. So these are the 3 things: define your aim, select your measure to understand if you've achieved your aim, and generate ideas that will take us towards it. and it's the ideas you test through Plan, Do, Study, Act. So that's a real whirlwind tour through those methods. The thing that I really want to say to both our communities, quality improvement and audit, is poor execution of any method undermines it and deteriorates the fidelity and the meaning of it. And there is a real danger here of this happening with both of these things. I see it with audit, with doctors in particular, who are asked to do audits and go around this loop and go off to the next job, around the loop, off to the next job. I know people have tried to get to doctors to be more strategic about it, and I think there's certainly some more joined up stuff that could be done around that, but it's not easy because your junior doctors are rotating and don't necessarily feel an ownership or an allegiance to your trust. But I think we've got to work on that. And with quality improvement, again, it has a method that needs to be respected and used well. And we're quite a long way from that, actually. There's some great examples, and there's also a lot of stuff that isn't. So we all have to learn, and I learn every day. You know, I continue to learn about all of these things. So I hope that's given you some food for thought. I'm just going to look at the chat and ask Craig and Claire if there are any very quick questions I need to address right now, and then I'm going to hand over to Craig, but we may have some time at the end for some questions.
Okay, Nikki, thank you very much. I think we can hand over to Craig, and Craig, if you could just make sure that you kind of explain your background in clinical audit and your views on clinical audit and how it differs to quality improvement, and particularly, I guess, the comments that are coming in on the chat around actually clinical audit done really well is often already done with PDSA cycles and already done with continuous data monitoring and all of those sorts of things. So bringing your experience to that to answer those questions would be great, Craig.
No
Over
problem.
to you.
Let me just try and share my screen 1 second. Are they the wrong way around again? Are they? That's the question.
Yes.
You're showing presenter review at the moment.
That's fine.
Craig.
Let me just change it 1 sec. I knew it would do this. It does it every single time. Right. Hopefully.
There we go. Brilliant.
Thank you.
Lovely.
Okay.
Thank
so
you.
Thanks, Claire. So yeah, I hopefully I'll be able to kind of answer, I guess, some of the things I've been reading in the chat around where I see from my limited experience, admittedly, but experience nonetheless. So in terms of my journey, I work at Sherwood Forest Hospital, which is a foundation trust just north of Nottingham. I've worked there just over 5.5 years. Prior to that, I didn't work in the NHS, worked in the energy industry. When I joined, our clinical audit team sat within governance. We had one person who essentially had a role in QI at our trust. And probably 1.5 years into that, into my journey in the NHS, I kind of, having got my head around what audit was and what it did, I then kind of started to think about, well, what do we do? Saw a lot of data being collected, but not a lot of improvement being undertaken. There was a lot of data being collected for assurance, but there wasn't a lot of us looking into, well, what do we do with that? How do we prove that we're making a difference? So a few conversations were had with that person who was managing or in charge of QI essentially at the trust, and we kind of found some common ground as to what we appreciated, that both QI and audit had a role to play alongside each other essentially, and that they could be both very beneficial, and that led to the teams merging essentially. So no empire building going on. Literally, it was we need to make a difference. We need to see that these things that we're doing actually lead to the improvement that we're looking for. So that's where we are now. So we sit within the QI team. Audit is still not separate, but audit goes on, and then we kind of link in the QI side of it. So in terms of how we kind of frame it, I guess, in our trust. So the graphic on the left-hand side here, so we have an audit, and that's what we see as our piece of detective work, essentially. So we look at that audit. Is it delivering against those standards? Do we meet the standards? If we don't meet those standards, what we encourage people to do, and again, we appreciate there's already been some discussion around time in the chat I've seen, it's not easy to do, but what we are trying to get people to realize is by spending some time doing a little bit more work in that kind of QI, using the QI tools, and actually it will mean that improvement will be sustained. So at that point, we ask that people undertake a QI project. And as Nikki's mentioned, we try and use the model for improvement. So we teach the QSA syllabus at our trust. So for those of you who may not be aware of that, that's for Quality Service Improvement and Redesign. It's a national course. We teach it within the ICB in Nottinghamshire, so that includes ourselves and some of our neighbouring trusts, including Nottingham University Hospitals, Nottinghamshire Healthcare, which is our local community mental health trust. EMAS are involved, so the local ambulance service, for example. And we're trying to build capability around QI in the whole of our kind of locale in the East Midlands. Once we've done that QI project, we would then use that audit data to try and understand that if that improvement has actually been undertaken by doing a re-audit. So that's how we frame it. And as I say, on the back of that first audit cycle, we would set up an improvement project using the model for improvement. So when it says project, yes, project's quite a big word, I suppose, in the sense, but what we are trying to encourage people to do is use some of those QI tools. So it's not so that we're actually using some tried and tested methodology. So we go through that, PDSA cycles, etc. And the example I'm going to share with you will hopefully give you an understanding of how we've tried to make that work for people. So when we've been teaching it, some of the things that we've talked to people about are, for that people understanding, well, what are we trying to get through here, is the go and see aspect. So we see a lot of people making assumptions that these are the problems. This isn't working. This audit, we're not succeeding in this audit because it's this problem, or this is the cause of it. So we're encouraging people to do a lot more go and see, have a look at what's going on, and understand what that problem really is, rather than just making those assumptions. There's been a massive increase in the amount of process mapping that goes on, for example. So people are working a lot harder at understanding how their processes actually work and where the changes maybe need to be made. We've moved away from people just looking at quantitative data. We tried to get people to look at qualitative data as well, because a lot of it was based on numbers, and we were trying to get some of that human aspect to it as well. We encourage people to try and use some of the discovery methods of why a problem might exist. So looking at causes using fish bones, driver diagrams as well, as I know Nikki's already shared as well. So some of those QI tools that help people frame what the cause of those problems might well be. So in terms of the audit, I'm going to talk to you about. So we do trust-wide audits, which I'm sure a number of us on this call do, that we have to do on cycles. And the one in particular that I'm focusing on is our antimicrobial prescribing audit. Now, our antimicrobial pharmacist attended our 5-day QI training, the QSA course. And day 2 is always measurement. And it can be a bit dry for people, to be fair, because measurement, run charts, SPC charts, if you're not a massive fan of maths, then it can be quite intimidating. That's the feedback we get from people. But what it led to on that particular day was a real light bulb moment for our antimicrobial pharmacist, who was essentially the trust lead for our antimicrobial audit. So when we're talking about RAG rating, for example, now RAG rating has its place, but sometimes it can make us look at the wrong things and take the wrong action. So when we went through that part of that session, it suddenly came clear to her that RAG rating, they were chasing reds and greens and reacting to those reds and greens in the wrong way. And what we were able to do is change their thinking, gave them some headspace, and allowed them to tackle underperformance that the audit was showing, but not just by, well, we've got a red this month, wow, we need to really do something about this. What we're able to do is make them understand that aspect of variation in a process, and therefore taking them through that journey of looking for special cause, etc., that actually might allow them to see where the changes actually made a difference. So a project aim that we set out, really important for you to frame how clearly and you understand what you're trying to do. So improve the standards of antimicrobial prescribing. They chose a particular ward because, again, audit, when we do audit, sometimes if we're trying to change an entire behaviour in the trust at once around this, it would be probably difficult to do. So they chose it small, decided to start small, chose one ward, set a fairly high target for themselves, really. 59% was the current target when they started that, and that was back in December 2021, and they looked to increase it to 90% by the end of June. So, but I guess if you don't set your targets high, then sometimes you can get complacent. So that's where they went from there. We set up meetings. So as an audit team, we got together, set up these monthly meetings with not only the antimicrobial pharmacists, but also some of our stakeholders, or the stakeholders that were really important as part of that. Sometimes something that's really forgotten, I find, in the audits that we see going on. So again, when people are making decisions around what changes going to make, we don't always involve the right people in those. So they use that QI methodology going forward. So understand the current situation. That was where the audit gave us that baseline of where we were. Understanding the cause of the problem, and I'll share some of the tools that they used, as I said, about stakeholders. So really allowed them to think about, well, who is this actually going to impact? Who have we got to keep an eye on? Who we've got to keep close to us to talk about this? They identified the aim and the measures that they wanted to look at. So how could they see that change that they were looking for would make a difference? By involving those stakeholders, setting up a team, because as we always try to encourage people to realise, audit and QI are a team sport. It shouldn't really be done as individuals, because everybody has different ideas. Everyone can come up with different solutions, but equally it's about sharing that load. So we work in such a high-paced, fast environment that has so many different pressures on us, and it's about sharing that load as well. So that's something else that we try to encourage by linking that audit and QI and methodology together. So again, it identified possible solutions, and I'll talk through some of the solutions that they identified and how they helped. They use PDSA cycles, so that's where we link in. As we said, PDSA can potentially link to or overlink the audit cycle as well. Measure over time. So they started collecting their data and displaying their data using run charts rather than that RAG rating that, to be fair, it's there because it's in our audit system that we use, so it's there anyway, and that's what they were working with, the tools that they were provided at that time. Using that PDSA, they were able to implement many solutions, but also identify the best solutions. So there were a couple of things that they tried that didn't work, so they were able to undo them because they'd done small incremental changes rather than big bang change. It was easy for them to undo it and go back. And also by monitoring that data in that way, they were able to make sure the improvement is sustained. And that was born out of that massive piece of work they did around stakeholder engagement as well, and making sure that everyone was involved. So I've deliberately shared these examples of what they put together are quite crude, to be fair, but and this was done in a piece of software called Miro, but it just makes you realize how accessible some of these tools can be. So they did a process map. It's really high level, looking at when the patient comes into ED, what they then do around prescribing in the trust. I'm not going to go into great detail, but it just showed that we were able to, before, what they would have done is just come up with an idea and gone ahead and just put a solution in place. They would have not done any of this discovery, try to understand, well, what's the process that we follow at the moment? Is it the right process for our patients? Does it give us the outcomes that we're trying to achieve? We also did a fishbone, so we've already seen a fishbone, I think, from recollect from Nikki sharing. So again, unpicking the problem, some of the different reasons that the problems that they were seeing, so that poor performance around prescribing on that particular ward, different factors that affect it. They also put this then into a Pareto chart, so they were able to work out what was going to give them their biggest bang for their buck, essentially. So they were able to tackle the problems that were going to deliver the biggest change by doing it that way. as well. So they did use the fishbone. They use stakeholder mapping as well. So some of the people on that, we've got medical director, for example, chief nurse, we've got junior doctors, we've got sepsis nurse, we've got patients, we've got various different groups. They were able to frame the way that they engage with the stakeholders. Now, so a couple of things that we teach when we deliver CUSA. One is that leadership triangle. So having a clinician, a CEO, and a project lead involved, because that's what we see as being the ultimate in delivering that engagement and that improvement. And they were able to tick those boxes by going through this exercise. Well, we had an executive on there. We had clinicians involved. We had, I say, people leading on the project as well. And then this is a driver diagram. So the arrows on a driver diagram can go either way if you want them to. So in their particular example, they've gone left to right. But again, this really helped them frame that problem. So they set out their aim on the left-hand side. They were able to understand, well, what are the primary causes to the problems that we're seeing here? What secondary causes then impact those? And then ultimately they set out those actions that they wanted to take. So some of the things that they picked out, their change ideas that were able to drive. And again, this was done as a group on the back of that data that they collected from the audit. So they created training video for people to watch. So they got our political illustration team involved and our training and development team who were able to work together, set up a bite-sized video for people to watch when they could. One of our doctors did lots of teaching, for example. They did podcasts as well, so they did a podcast that could be watched at any time. They held meetings to discuss it with staff. They went and did some side-by-side kind of visits with the staff as well on the ward, just to check that they were comfortable. Did they have any questions? Lots of different bits and pieces that were done, proving that you can't just make one change necessarily and expect there to see an improvement. So we had a suite essentially of improvements that they wanted to make. One of the things that we have, again, tried to instill when we're thinking about some of those change ideas is this hierarchy of effectiveness that was published in the BMG about 6 years ago. So traditionally what we'd seen and what we tend still to see, this is a journey that we're still on as a trust. We're still in its infancy, although we've been merged. Audit team and QI team have worked side by side for the last 3.5 years. We're still doing a lot of work around this, and this is around the effective solutions that people choose to put in place. So what we tend to see a lot of our posters, we'll put a poster up on the wall of our ward to tell people how they should do things differently, or this is how you should do it, which become noise, for example. So once you see a poster's been up a couple of weeks, you perhaps don't notice it anymore, but some of the other things on there, so things like education, training, don't have a sense of longevity. So although they were the initial ideas of improvements that they used on the project, we encouraged them and kind of tried to reiterate the idea that those sorts of actions around training are only as good as training the people in the room at that time, and people tend to maybe go back to the different ways of working. Some of the other things that they've looked at doing, they've put checklists in place, for example, but we've started teaching this as part of our in-house training as well, around how a lot of the time when we're undertaking change and we're looking at the results of audit, sometimes more often than not, it's the cultural side of things that need to be impacted. It's people's behaviours, and we need to put things in place that allow people not to fail. So if we look at the human factors side of things in improvement and audit, we need to make sure that people are being given those mechanisms to actually do the job that they're being asked to do, so they can't make the mistakes that potentially are leading to our poor performance in audit. So in terms of data, just to go back to the point I was making, this is how the dashboard for the antimicrobial audit is displayed at the moment. So what we generally see is everybody would run around celebrating how well they're doing on question 1, but then they'd be really anxious around some of those reds on there. So one of the things that we've kind of used to teach them is this idea of this two-point comparison that we see. So we get a result last year, we make a change, and the first month after that change, we see that fabulous improvement. Looks great because we've increased. What we've tried to do is encourage them, as I said, to share the data that they're using over time, so that I do time series data rather than that 2-point comparison. So if we were to look at the data from the previous slide, for example, all we can see there is some normal variation actually. So yeah, it looks like we've made a massive change because the increase in is quite clearly showed there. However, potentially that's just part of our normal process, and that's how the data would have gone, whether we'd made that change or not. So this is my final slide, and it's a bit busy, and I apologise for that. But this is the data now plotted on an SPC chart for the antimicrobial prescribing audit, rather than in that RAG rating. And if we look at some of the interventions, then we can see first thing that they did back in towards the end of 2021 was a podcast, so a nurse podcast. That necessarily didn't lead to any change. They added a checklist in at the beginning of 2022. Some of the teaching was done, more teaching, for example. And then it was only in kind of February that year that we started to see an improvement that actually looked like it was genuinely leading to that change that we were seeking. So by describing and putting the data out for people to see like this, it was easier for them to see where the change was happening, and also that it was sustaining potentially over time. So thank you for giving me the opportunity to talk to you this morning. And as we say, if you've got any questions, then I'll stop sharing my slides now.
Brilliant. Thank you very much, Craig. Okay, so lots of debate in the chat, which is great, and this is intended really to help provoke those discussions about, are they the same thing? Are they different? How do they fit together? Are we already doing it? And I think just one reflection from me is, certainly I've been involved in being in the same position as many of you, and being a sort of head of clinical effectiveness and running audit programs, but I've also, my big part of my background is QI and sort of running that at the organisational level. And for me, they are distinctly different methodologies which have rigour, evidence behind them, but areas of overlap that mean that if clinical audit is done well, it already incorporates many of those principles around QI. And I think a lot of what's being said in the chat around, but audit does this. Well, done well, audit does look at data more frequently. It doesn't do the 2-point analysis. It does look at things over a longer time period. And I loved the comment in the chat from Jan. And if I get the gist of your comment right, Jan, please correct me if I don't, was the importance of focusing on not just saying, oh, that one's okay, we're 95%, great, tick, but actually, what about the 5%? That 5% is a huge number of patients that we are failing if we're not meeting that standard. So, you know, there's lots of overlap between these methodologies. And I'll just pass over to Yonya for questions.
Okay, folks. We're 6 minutes to the hour.
Yeah.
But just so you know, I'm gonna drop the link to the Q community here afterwards, and we can continue this Q&A in our clinical audit page. So if you post your questions over there in the next, let's say 2 days, I'm gonna invite the speakers to go over there and answer your questions via text. We lose this live moment. We also get the opportunity to deliberate a bit more and answer questions with a bit more time and patience. But since we still got 5 minutes there, I can see Albert is already doing the right thing, which is use the Zoom function of raise hand, which is under the reactions button in the, you see this bottom menu with a couple of buttons. One of them is reactions, and you find raise hand over there. And I would ask you, since we're so many, to focus on questions. Sometimes we have time to process a lot of information here, but we're 360. So let's focus on the questions for today. Albert, please.
So hopefully you can hear me. I wanted to say thank you very much for the presentation. It was very good. There's just a bit of feedback, really. There's a diagram that you used where you had two pink pie charts, one that says compliance and one that says learning, which I think is supposed to try and demonstrate the difference between audit/clinical audit and quality improvement. Now, we do have clinical audit specialists in our team, although the team is primarily made up of people who have knowledge of quality improvement. I don't necessarily feel, and I don't know if this was the intention of the presentation, that the distinction between quality improvement and clinical audit has effectively been demonstrated, because I am still not clear whether or not they are supposed to be the same thing. Whether or not they are supposed to be different. There was a comment that was made that QI projects are quick. They're certainly not a week long in our department. Quality improvement projects can be anywhere from 6 months to a year. So some of the feedback it's been a very interesting presentation. Makes me wonder whether or not we're doing QI properly as well.
Can I come in on that, Julian? First of all, QI projects are not necessarily quick, but the PDSA, Plan, Do, Study, Act cycles that you do within them are the things that should be short and quick, particularly when you're first doing them, because you're using them to build confidence and to test ideas. And it's only once you start getting confident, having tried on one person, one doctor, one ward, that you start growing them and start using them with more patients or more doctors or more nurses or more wards or whatever. So it's a very incremental thing. It's a really iterative process. The quality improvement I've been talking about is around improvement science. So that is using models. Now, the model of improvement is not the only one. There's also lean methodology, which sometimes is incorporated into, I mean, I use that alongside some of the stuff that I use. I'm not says it's got to be one thing. But just sort of looking at those sciencing, I'm just going to hold up this book, which many of you won't be able to see. This is the improvement guide. It's a huge tome written by the people who thought about all of these things. If you can get this as a reference book, and it is only to reference, it's really brilliant. But actually within that, I just looked up audit to see if it mentioned clinical audit, and it doesn't mention it anywhere. So I have been talking about quality improvement that uses these specific methodologies. The NHS has peddled a lot of other quality improvement type of things in the past, some of which are better than others. The ones that use measurement are going to be the really strong ones that you want to go for. And I can see Claire's going to come in on that too. So I'll let Claire have a go.
Brilliant, thank you. So for me, this is an absolutely really important question, and I apologise for taking any time away from questions. Hopefully you can see my slide deck. So in preparing for today, I did some reflection in terms of thinking about, okay, well, are they different? Are they the same? And I think what's happened is that there's a lot of theory, there's a lot of book learning that we do, there's a lot of study that we do with PhDs and masters and all of those things, and we look at it from a very purist point of view, and we look at definitions of quality control, quality improvement used in other industries. And actually what I've tried to do with a graphic that I will send to people after the session is to think about, well, yes, but that's not exactly how it's worked out in the NHS. And actually, well, if we're stepping back and saying, what do we really mean by quality improvement and how is that different to audit? Then we need to be a bit clearer with some of our language. So a lot of the time we will say clinical audit is a quality improvement tool. And the reason why the definition in the HQIC guidance and also in the NICE guidance talks about it being a quality improvement tool is in order to emphasize that audit is a great tool to be able to make improvement happen, to improve the quality of care. Now, over time, that's led to a real misunderstanding about what the methodology of quality improvement is. And so in my depiction, I've changed it to actually, we've got a host of methods that we use to improve quality. And some of those are actually quality improvement in the way that they can be officially designed, sort of defined, and some of them are not. And sometimes it's a mixture of the two. So for example, the lean methodologies and use of queuing theory and all of those things we do in what often is termed transformation in the NHS. But actually, sometimes we follow QI sort of principles and we involve people on the front line, for example, we use data systematically, and sometimes we don't. I guess for me, one of the key things that I would love people to sort of see as the difference really is the mentality and the philosophy behind it. So if you're using clinical audit in order to ascertain where you are, in order to be able to then move forward, that's great. That is exactly what we want. Either we're providing data upwards for assurance, in which case we still need to make that improvement, or if our intention is improvement, that's great also. But what the QI part adds, and what I've kind of added to my pictorial thing, is for me, it's about that system. So our view as QI practitioners of healthcare is that it's a complex system with lots of stuff all interacting in a way that you can't always predict. And so what we do with our methodologies is try and understand why. And it particularly focuses around the human element of it. And that's why training and raising awareness doesn't always work, because it's a complex mess of things. So when you've got a complex problem, that's when the QI methodology can really enhance what you're already doing with clinical audit. And I'll stop sharing now. Okay, that's just my view.
Ruth with a question, but I don't know if she's got time to do that.
Well,
back to you, Joran.
We're at the hour right now, folks. So
can we have maybe one more question, seeing as we have people here?
Sure. This is great. It's just recognizing that some people need to leave.
Absolutely.
And actually, I'm going to do two things at the same time, so you folks can excuse me. Ruth had a hand up, so it has the preference, but I'm also going to run the feedback form as we ask the last question.
Perfect. That's great. Thank you very much.
Just to be efficient. We have time for one last question, folks.
I won't take up time with the question because my question is a little cheeky. But I will sign up to the group and put it to the group, but just for context share, because I'm deputy manager of a clinical audit, and you guys spoke about run charts, and so I just wanted to ask about.
Let's have a chat. We can have a chat.
Yeah, we can put that somewhere. Thank you.
Okay. I have one more comment I'd just like to put in. Somebody put up the question about clinical audit as a tool of quality improvement. Well, in the bigger sense, all of our tools are part of quality improvement, but also look at the debate and the narrative around where human factors science. Craig mentioned that there is a whole body of science around human factors. I'm a trustee of Clinical Human Factors Group, so I have some knowledge and insight into it. And I want to say about that is, again, that human factors science is very good, but it doesn't actually always do the implementation very well when you start moving from one site to another site to another site. And that's where you need to be much more exploratory, much more curious, and have some tools to help you do it. Whether it's clinical audit or anything, you have to, because you've got to adapt and adopt to every place you're working in. We know what the NHS is like.
All right, folks. Unfortunately, we don't have a lot more time today. I just posted another link if you want to give more qualitative feedback to our session. Thank you so much for filling this little poll that we had at the same time that we were answering questions.
Thank you very much, everybody, and thank you to our speakers. Let's continue this debate. Let's continue the conversation. And anybody who wishes to can always contact me outside this session. Okay, thank you very much.
Thank you.